Dr. Rodriguez, I'm so happy that you are joining me on Fempower Health today. It was so fun getting to know you the first time right before you went on vacation. So I'm sure you're fresh and renewed and perhaps now forgetting that you were on vacation.
Yes, I mean,
Deep
it's
in the
been a
grind.
little over 2 weeks, so I don't even know where I was.
But nonetheless, thank you so much for being here. I've been really wanting to talk about hysterectomies on Fempower Health because I hear these stories of things like women will wake up from a surgery and they're like, hold on a second, I didn't know that a hysterectomy might be happening. Um, there may be, situations where women didn't know options of partial hysterectomy versus a full hysterectomy. The other thing I commonly hear is women will have their hysterectomy and we're not given information about what will happen after, such as the massive hormone decline, and they're not prepared. So these are just some of the things that I've been hearing. And so I thought, why don't I find an expert where we can just talk about all this stuff? And you
Yeah.
shared some really interesting cultural dynamics as well. So
It's obviously cultural differences in how certain patient populations view their healthcare providers, and how they view what appropriate treatments are. And I find that working in New York with such a heterogeneous community, and also with a large Latina community, because I am Latina as well, I'm a first generation American. It's very interesting how Latin women view definitive management with hysterectomy versus, non-Latina women. So it's kind of fun to, straddle those two as well. It
oh
gives me
my
an interesting
gosh.
perspective.
Yeah,
Yeah.
absolutely. By the way, I'm also first generation. I think when we spoke last, I knew you were a Latina woman, but I did not know that you were first generation. So I'm
First.
Hungarian. Um,
Oh, cool.
so yeah, very interesting. So why don't we talk about some of these misconceptions that women may have when they're undergoing, like, let's talk at like a broad level what you're seeing,
Whoa.
because the thing that is always fascinating to me doing this podcast is, especially with social media, you know it's clickbait, you have sensationalism that gets you in the feed on social media. And so this is why I like to talk to clinicians, because it's like you're seeing all the patients, not the one social media feeds you. And so I'm sure there are all sorts of stories, and I'm not at all diminishing the horrific experiences that women may have. But I this is why I wanted to talk to you. So maybe at a broad level, you can talk about like just some of these misconceptions that you're seeing people coming into your office.
Um, but I think the biggest misconception I find, and I kind of nip it in the bud very early on in our visits, but I do feel like there's this misconception that, we Western physicians are out to operate on everyone. We're out to take away everybody's uterus. Um, and, and, to some degree, I understand it, because I think we spoke last time about the long history of paternalism and misogyny in medicine. Still some misogyny in medicine. Luckily, the NIH is now going to give out, you've heard that, they're going to like make a point of giving out money for studies that focus on women's health issues, because historically, it was only men that were being studied, and all of these findings were extrapolated to us as if we share the same physiology and the same risk factors. So there is a history of misogyny, not just in our field, but across medicine. And there is a history of paternalism, probably stemming from that misogyny. And I try to break that every day. I really do. But I do feel that people come in with that misconception, with this like historical, let's call it generational trauma, right? That like the lack of trust. So I feel like that's the biggest misconception when people walk into my office. And then if we want to go the culture route from my Latina community, their misconception is that doing the hysterectomy will cure everything. I have people coming in all the time, like, just remove it. I don't need it anymore. Like literally saying things like that. And I don't think that's exactly what they mean. I just think that that's how they're expressing themselves. But I spend a fair amount of time really educating people on what that means and trying to refocus them on their symptoms and ways to treat it. So it's kind of like I have the Latinas walking in with a more paternalistic view and I'm trying to debunk. And then I have other women coming in, assuming we have a paternalistic view and I have to debunk that. So it's kind of fun.
Interesting.
Yeah.
So back to the, surgeons want to do surgery. A question there. I did an interview, I think it's now 2 years ago, talking about uterine fibroids. And I had understood that ACOG had put out, I guess it's not a mandate. I can't think of the word at the moment.
Practice bulletin with
practice bulletin. Thank you.
Evidence-based recommendations.
Correct. And it was really about, let's not automatically do a hysterectomy. Let's figure out what else to do first.
Yeah.
So can you talk about that dynamic? Because I know when we spoke last time, you had mentioned that with minimally invasive surgery now becoming more prominent, it's the hysterectomies aren't as like, let's do this first type of thing. So can you talk about where we are with that? Because I would also presume different parts of the US are very different in how they view it. So can you just give us like the rationale of why that was in place and why it needed to be in place, just to give people some perspective?
Well, I mean, I think governing bodies putting out evidence-based recommendations is just part of, helping guide physicians make informed decisions with their patients, helping provide the evidence behind it, and taking that evidence and making it relevant to our practices. So I don't think that it was put out because like, oh wow, we have to really speak to this elevated hysterectomy rates.
Okay.
We really got to tell the doctors the way it is. They put out practice bulletins on all sorts of recommendations.
Okay.
For obstetrics and gynecology alike. But the nice thing about having them, publish this is that it does give doctors guidelines and it does provide the evidence. And it really nicely very went through like, these are the things you should consider, which many of us already know, right? So you want to first try with, you talk about fibroids specifically, fibroids can really respond to medical treatment. So historically, it was always the birth control pill. We have other non-hormonal means of treating fibroids that help reduce the amount of bleeding. Even taking Motrin in an intentional kind of, way can help reduce bleeding. And we have another medication called tranexamic acid that's incredibly effective and is great for people who have contraindications to hormonal management of bleeding. And what has happened is that, so we have this advance in medication that we can offer, but we also have advances in devices we can offer, like depending upon where the fibroids are and how big they are. And, you can offer management with hormonal IUD, which is very effective at significantly reducing bleeding and sometimes even leading to no bleeding at all, which is great. So you want to exhaust all the medical ways to treat the fibroids. Then we have other minimally invasive ways to treat it because, what's interesting with fibroids is that every uterus is different. And, some of the treatments that you may offer your patients may depend upon where the fibroids are located. Is it within the muscle of the uterus? Is it inside the cavity? Is it on the outside? And to just go back a step, what's very important is to make sure that patients are getting the appropriate imaging studies that their doctors need to help patients make an informed decision on what treatment is best for them, because it could vary depending upon where the fibroid is. For instance, fibroids that are inside the cavity, what we refer to as submucosal fibroids, right? Those are more difficult to control medically. And certainly you can't place an IUD inside a cavity when there's a big fibroid in there. So those you might just need to resect. But guess what? When I was a very young physician, they didn't have the ability to remove fibroids by putting a camera through your cervix, through the vagina into the cervix, and remove the fibroid without even making an incision on your belly. So there were women who had a fibroid inside their cavity who were having hysterectomies, and we're no longer doing that, right?
Got it.
So I think that making sure your doctor's doing the correct imaging, and sometimes it may require something like an MRI, which is a bigger deal because you got to be in that thing and the loud noise. I get it, but it's very good at really characterizing exactly where your fibroids are. So now we have hysteroscopic myomectomies. That's what it's called. The hysteroscopy is when you put the little camera through the vagina into your cervix. And that's been a game changer. I mean, there were people, you can remove polyps that way too. I know we're not talking about polyps, but it used to be that people 30, 40 years ago were getting hysterectomies for a little polyp that we now remove in our offices. Now we remove them. I just removed one 20 minutes ago.
Wow.
So it's really great. And so it's good to speak back to, the practice bulletin. It's good to put all of that in one document as a reference point.
Okay. Got
Now,
it.
when you're talking to patients about treatment of fibroids, since we're on the subject, so you have the medical treatment, excuse me. You have medical management with the hormonal IUD. You can do minimally invasive procedures like putting the camera in and removing any fibers that are in there. We also have other more advanced minimally invasive procedures that use radiofrequency ablation. So you put a camera through the cervix, and there's someone doing a sonogram while you're doing that, and you can actually ablate fibroids that are in the muscle. So you can't really access them from below, but using this device and an ultrasound from above, you can access these small fibroids that are in the muscle of the uterus. And again, no incision on the belly, no overnight stays in the hospital. So things are really looking up as far as offering other minimally invasive treatments for fibroid bleeding or pain, which is
Right.
great.
What are some other common reasons why people need to get a hysterectomy? I mean, I know endometriosis, and by the way, endo is so complex. If you want to summarize anything specifically,
You
feel
need
free.
3 podcasts for
I did
endometriosis.
a 4-part series
Yeah.
actually earlier this year, and we
Yes.
covered everything. I had a surgeon, pelvic floor
Good.
PT, I had a patient advocate, and another patient advocate who's building something to help make sure it's caught earlier by mining EMR records,
Yeah.
or
Yeah. Yeah.
EHR. You know what? I'm actually wondering if those are interchangeable. I've never thought about it, but I feel like people interchange it.
Yeah.
But
I think
anyways,
it's fine.
electronic health records. And so I have done a whole thing on that. So if there's any summary you want to give, feel free. But I just wanted to let you know it has been covered. So if anyone here is wondering anything about endo, we got that.
I'm just so happy that endometriosis is getting this kind of attention.
Right.
I'm delighted because, talk about misogyny, like, oh, pain is normal. Like people, I know I'm getting a little bit off topic, but because of the menstrual cramping that people experience, that is considered normal. It is considered a normal part of being a person who was born with these reproductive organs, that people normalize pain in any venue for women.
Yep.
Or people assign female at birth. Like it's maddening is what it is, that pain is normalized. And I'm so happy that endometriosis is getting the attention it deserves. And thank you for doing, I'll look up your 4-part series and get a little ramped up on what your experts discuss.
Yeah.
Very interesting.
It
So
was
other
cool.
indications. So obviously fibroids is probably the most common reason. Other indications obviously include endometriosis, obviously a variety of malignancies. Like I mentioned earlier, it can be part of gender affirmation. Not every transgender or non-binary patient chooses that route, but it is an indication for hysterectomy. And then there's like pelvic organ prolapse, right? So sometimes in order to treat someone's prolapse, you need to remove the uterus so that you can suspend the vagina or the bladder, or whatever is prolapsing. So those are the main indications. I think I may have got all, but yeah.
Well, and certain cancers and things like that, I assume as
I
well.
mentioned malignancies. I'm sorry you missed it. Sorry. Yes.
Yeah.
Yes.
So the I guess a question there then is, there can be a partial hysterectomy or a full hysterectomy.
Uh-huh.
How does one determine when? And I guess what are the types of questions that patients should be asking to make sure
Yeah.
there's the right discussion? Because there's this nuance of informed consent. And here's kind of my view on it, by the way. I'm sorry, maybe I'm getting off track, but
No,
let's
give it to
remember the
me.
question. So, I think about this. I mean, I've talked to so many experts and so many women, and I think to put it into perspective, we as women don't know all the things we need to know, and many things are normalized. And we're busy and we take care of everyone else. So we don't always track, given that entire dynamic. We don't track or we don't know what to track. Then we have the clinicians who see tons of patients. They see you for 10 minutes. If you're lucky, you get an hour appointment, but they still only know 10 minutes or an hour of your life. So if the perfect little nuance that would completely change your treatment pathway happens to not be covered because the physician is busy and forgot to ask, or wouldn't have even thought to ask, or the woman didn't bring it up, that could affect the future, right? And so I feel like we can't do this whole like the doctors are terrible or gosh, these patients are annoying. It's like this, it's a dynamic.
Totally.
And then there's reimbursement pressures, cost pressures,
Copays.
incentives, everything. Like it's such a hot mess. And
Yes.
so, um, I say that, so I feel like I do the Fempower Health podcast with the main focus of women. Here's what the doctors are saying. Like, you
Right.
gotta do this stuff, do your
Got
homework.
it.
And then for the clinicians who listen, it's like, oh, that's such an interesting perspective. So
Yes.
I hope I'm serving both parties effectively.
Yeah. Okay.
But going
So,
back, partial,
yeah,
full, informed consent,
I
like
love this
how does that
question.
dynamic happen?
Um, so first, I think it's super important to define what the difference is between a total hysterectomy and a supracervical hysterectomy,
Okay.
because partial is not the medical term, although I know it's become, lay and widely used. I want to define it because people get confused because they think partial hysterectomy means you don't remove the ovaries. And removing the ovaries is a whole separate procedure in and of itself. So if you're going to have a total hysterectomy and removal of the ovaries, it's called a total hysterectomy and removal of the ovaries.
No way.
So, right. So
I thought total hysterectomy was uterus and ovaries.
it's not.
No way.
It's
Okay.
very
Continue.
confusing for the people.
I did not
So
know.
and it's super important. So total hysterectomy means that we remove the uterus and the cervix.
Okay.
Because that's the uterus, and hysterectomy is removal of uterus. So it's the uterus and the cervix. And then removal of the ovaries is a separate thing. It's called an oophorectomy. So a total hysterectomy, you remove the cervix. A partial hysterectomy, you leave the cervix. So do you want to hear about supracervical hysterectomies, or do you want to hear about, like, do we remove the ovaries or not?
I mean, now I have no idea how to ask this question because so you're the expert.
We could
You
talk
tell me
about the
what we need to
ovaries.
know.
We could, I don't know, whatever you want to talk about, Georgie.
Okay. So, okay, here's what I will say is, whoops, I think what the way I would look at this is
Yeah.
from the patient's experience, what they should expect. Because again, like these nuances, like I've been doing this podcast for how long? I literally had no idea that the partial or the total
I'm so happy to change your life.
did not
This is
include the
wonderful.
ovaries. So I literally learned something new in every episode, and that is the new today. But I guess let's think about it from the patient. Like,
Yeah.
what matters to the patient of the difference between removing just the uterus or the cervix and uterus, and then now add to that the ovaries? Like, what happens? Because I have a feeling when they leave the surgery, different things happen to their body, which means different things need to be told to them. And if someone doesn't, they probably need to know from you. So
Yeah. Yeah.
educate us.
Okay. So, you know, when I'm sitting with a patient and we decide, okay, I'm going to have a hysterectomy for whatever reason, all of them except cancer because I don't work in that field. Then I explained to them what parts we're going to remove. So I said, okay, so the uterus and the cervix, and then depending on their age, we talk about, and the indication, we talk about whether or not we're going to remove the ovaries. So when they're like, what do you mean the cervix and the uterus? What does that even mean? How do I make a decision? And then I let them know, look, the fact of the matter is that as the people who leave the cervix behind, the surgeons who leave the cervix behind, they have a different take on what that can do for sexual function, right?
That was my next question. So thank you for.
And the evidence doesn't support that wholeheartedly. There's some conflicting evidence, but for the most part, we do recommend removal of the cervix. Now, if I have a patient who is like, I want to keep my cervix for whatever reason, I don't even ask, meaning I'm not going to stand in judgment on whether they want to keep a body part that's not causing any problems for whatever reason, right? But obviously they need to have had a history of normal PAPs all along, right? Because you don't want to leave a cervix behind where someone has had a history of dysplasia and then, the risk of cervical cancer. And I also remind them that they'll need to continue to have cervical cancer screenings, the PAP that would be done at whatever cadence is indicated for that patient. So we have that, and it's a pretty brief discussion that we have about that. And most patients in my practice choose to have their cervix removed after kind of talking to me. Then the issue of removing the ovaries or not is kind of age and indication based.
Okay.
And we can do a whole podcast on this as well. But generally, if you're younger, and the number used to be actually like 65, like if you had normal ovaries and you were having a hysterectomy for benign indications and you're under 65, we should leave your ovaries, because even though the production of estrogen is significantly reduced, there's still some activity, a small amount of testosterone that's produced. So it was kind of like this no net harm would be caused, but potential benefit to leave the ovaries. And recently, actually, is in one of the papers that we had to do for our maintenance of certification, there was this big study done. I think it was in Canada. I don't think that matters, but it turns out that in looking at all the data, it looks like the net benefit of removing the ovaries actually should be 50, because it could potentially increase life expectancy.
What?
Yeah.
That is logically, and my brain is like, what?
I know. So that's so the risk of death can be increased if, I'm so sorry, was it 50 or 55, Georgie? I think it's 55.
Okay.
Because I remember thinking perspective at my age. So like the risk of death was slightly higher if you remove the ovaries prior to the age of 50, and slightly lower if removed after the age of 55. So I'm going to take back the 50s, 55.
Okay.
So whether or not people have put that into practice yet, I don't know if that has been widely accepted, but that's kind of, and you always have to new data comes out, new analyses come out. And oftentimes in medicine, there's that big pendulum, when I was a very young doctor, everybody was using menopause hormone therapy, and then
I know.
we got caught up at the knees, and now everybody's re-embracing it again.
That's right.
And by the way, if we remove the ovaries, obviously we can reduce those risks a little bit, presumably by providing patients with menopause hormone therapy, right? So that's
well, my understanding is when the ovaries are removed, and this is, by the way, this is so interesting. I'm now trying to figure out how this whole thing caught on, where I always thought total hysterectomy meant ovaries and uterus.
Oh, you're still
And
on that? Okay.
well, no. There's a whole reason behind this because
Using it.
I know, but like, and because I think women have to be clear, like, let's be like, I think we should always triple check with our doctor on what's happening. I think the clinicians know, but I think we women have to triple check. And I say this because my understanding is if the hormone therapy is not given when the ovaries are removed, they can have a major crash, for
Mhm.
lack of a better word. I don't know the medical term, but because of that
Yes.
massive hormone change, that's just like, it's not
Surgical
like,
menopause.
right. It's not like you get the perimenopause and then menopause. It's like, hello, and
There's
here
no
we are.
glide path.
Right. Except the glide path is not that fun. I'm in menopause now, but boy, that was crazy.
Yeah,
Nonetheless,
it's like going through puberty again. Yeah.
yes.
Mm,
So, that crash, so to speak, because you're now
yeah.
in the surgical menopause, like right when that happens, what what are the things that women should be told about and prepared for, and what are the options? Because it was interesting. I would have assumed you said you must go on menopause hormone therapy because it's going to be a really hard time right after that, and you're not saying that. So now I'm curious, medically, like what women should be told as far as like, here are signs that you should look for, so it's not an automatic, oh, you just had a hysterectomy, here you go, here's a prescription.
Yeah. Okay. That's a lot. So here's what I will tell you.
Need it to be
It's a lot. So, you know, I had a patient recently.
right.
She's 46, 47, late 40s. Regular periods, not in menopause. We tried everything for her fibroid, heavy bleeding. She had to get transfused. She had anemia. I was like, that's it. We're done. Or maybe she told me. Usually patients tell me that they're done. I don't tell them I'm done. So she's like, I just want the hysterectomy. I said, okay, great. So, and then I go through the organ inventory. Like, we're going to remove the uterus, the cervix, and the fallopian tubes, and we'll leave your ovaries behind because of your age and blah, blah, blah. She's like, great. And I say, if I see anything wrong with the ovaries at the time of surgery, we're going to have to remove it. Okay, perfect. So that's great. So now she's 46, 47, and she had a hysterectomy, and we left the ovaries behind, right? In people after 40 who, let's just look at the people after 40 for now, not the people before 40. The people after 40 who who don't have their ovaries removed, they're still at risk for earlier menopause, right? But I get to have that discussion with them. I say, look, this is going to protect you from going to menopause right after the surgery. I don't know what's going to happen. You don't know when you're going to go through menopause because you're not going to be bleeding anymore. That's the purpose of the surgery.
Oh, okay.
So I need you to really pay attention to your symptoms because that's the only way I'm going to know. And if you pay attention to your symptoms and you are having symptoms, then I can just provide you with these beautiful menopausal hormone therapies that I think are perfectly indicated for you because you don't have this, that, and the other. We go through the whole thing. So there is a discussion of what to expect. Now, whether or not she'll remember that, I don't know. But we mention it at each visit.
Okay.
How are you doing? Are you having menopausal symptoms? Are you not having menopausal symptoms? Not everybody has menopausal symptoms. Not everybody's as lucky as you, Georgie. So, so, so we have to kind of prompt the patients to say, you got to tell me what's going on so I can provide you with this menopausal hormone therapy.
Right.
Okay. Because there is a risk that, the average age is 51. It may be sooner. I don't know. Even though I preserved your ovaries, there's still a disruption. The theory, of course, is, I don't know that we'll ever know, but the theory is there's a disruption of the blood supply to the ovary because everything is all connected. I wish we had like a little picture of the uterus and ovaries, but there's tissue that connects the uterus and the ovaries. Is very fine tissue that has all these blood supplies coming in. That tissue gets disrupted when we're performing the hysterectomy and removing the tubes and leaving the ovaries. So that's probably why we may see increased risk of going through menopause a little bit earlier for women over 40, even with ovarian preservation.
Okay.
So what else?
But then if you remove the ovaries, to me, that would be when there's the quote unquote crash.
Then
By the way, to clarify, I am on menopause hormone therapy now because my executive function was out of control and I finally traced it back. And I'm like, hold on a second, because I had my son at 41, and I think I was going through perimenopause while I was going through fertility treatments. And I traced everything back because I was like the doer. I was known in the healthcare industry as the person you go to get things done. I'm like, yeah, I am not that person anymore. I am back. Like, I
Yeah.
cannot. Anyways,
I'm so happy. I was always on board with menopausal hormone therapy. I was not one of those physicians who stopped recommending it. I'm a big fan. I'm so happy that so many of my patients are doing so well on it now. Like
yeah,
everybody's
yeah,
kind of on board, which is really
it's life
great. I'm so
changing.
happy for everyone.
Yeah, it's
Yeah,
life
yeah,
changing. Nonetheless, so if the ovaries are removed,
yeah.
what do patients need to be warned about? Because I've had friends who've had the hysterectomy and they're like, my doctor never warned me. And I was like a mess
Oh,
after.
yeah. So I forgot your question, but what we tell, okay, I remember now. What we tell people about menopausal symptoms, if the plan is to remove the ovaries, it really depends on their age.
Really?
Like I, many years ago, I had like a 36-year-old who had such bad endo. She's like, I'm done. And I want you to take my ovaries. And it was like a big deal. Like I had to fight with the insurance company because they didn't even want to pay for her hysterectomy.
Oh my God.
She was like in her mid 30s. They wouldn't, they're like, no, she's too young. This is what they're selling me. This is like 10, 15 years ago. And I really struggled with that. So, she's like, I will take the estrogen. I can't risk that I will need multiple surgeries. That's how done she was.
Oh, poor
And
thing.
we got there and, she just, she started taking her hormones and it's great. So it really all depends on their age. If it's somebody who's already gone through menopause, you're going to say, I expect little to no change
Got it.
to your symptoms, right? Because I don't want to say 100% that the ovary is completely inert, right? Because we do know that there is some sort of hormonal production, but I wouldn't put the fear of that in a patient's mind. And I'll say, look, if we do remove your ovaries and you're past menopause and you're having symptoms, we can have a discussion and try if a little bit of estrogen works,
Okay.
and there's always room for that discussion as long as hormonal treatment is not contraindicated, of course,
Right.
always that caveat.
So it isn't a black and white hysterectomy. Here's your prescription for hormone therapy. Or sorry, what is the term for
Oophorectomy. You can just
oophorectomy?
removal of ovaries, yeah.
Yes. So for the oophorectomy, because I got to practice this now. So for the oophorectomy,
It's a mouthful.
right? Like I'm going to say it like 10 times. So I think I got it. So for the oophorectomy, see, I got it. So you don't always need the menopause hormone therapy. Like the next day, you don't have to walk out. It's going to be dependent on a lot of factors, and the patient should just be aware if you're like having XYZ symptoms, you got to call me.
Yeah, I mean, and it's also age dependent. Like
Yes.
if you're removing the ovaries on a young patient, for whatever reason, benign indications. I don't want to talk about the cancers because that's like another 6-part podcast.
Yes, exactly.
But I may say, and your pain meds and your hormones will be waiting for you at the pharmacy. You know what I mean?
Right.
So it all depends
Okay.
on their age, and all of it is. It's so easy. It's a risk benefit discussion, and it's using an individualized plan, using evidence-based medicine from a large population, right? So that means you have to take your patient's needs and concerns into consideration, their age, their special circumstances, and you can come up with a plan together.
Okay.
And look, what I will say is, because we started talking about like pre-op stuff, like there are times where I have maybe 2 preoperative visits from my patients, right? So, we may sit here and decide, okay, we're going to have surgery and I'll go through the whole spiel. But then I always have them come back in like 1 to 3 weeks before their surgery because a lot of people don't remember what you say, which is very common. And you want to also provide patients an opportunity to ask questions, clarify things, go through the logistics of like, what do I do to get ready for hysterectomy? What do I do afterwards? Which I think is part of the stuff you wanted to cover. And it gives them an opportunity to be like, you know what, the ovary thing, am I keeping them? Am I removing them? Because people forget, people have their own busy lives. And to your point, we have like 15, 20 minutes with them. And I'm using that 15 to 20 minutes, like no fluff, because we have a lot to get through. But the brain cannot process
Right.
20 minutes of information with no fluff. So I try to take that into consideration. It's difficult when you're so busy, but I do try to take that into consideration that, look, I'll give you a perfect example. Talking to a patient, I say, okay, it's time for the exam. I say the same thing every time. I say, so I'm going to step out, just remove everything and just put the gown with the opening to the front and sit on the bed. That was 12 seconds of the instructions I give every time.
You're right. I forget sometimes.
15% of the time, this is not a validated number. 15% of the time I walk in, the gown's all like, they're wearing like a toga. I don't know what they're doing. And I'm like, do you not pay attention to what I say? And then I'm like, of course they don't, which is why you have to repeat things over and over. And you have to have multiple visits. And patients hate that part because depending on their insurance, they have out-of-pocket expenses for multiple visits. But it really, really is the best way to get all the information you need. And the wonderful thing is that now with like everybody has embraced telehealth, the only good thing to come out of COVID, I think, everybody has embraced telehealth. So it makes it a little bit easier to be like, okay, let's chat for 15 minutes. We're on the camera, blah, blah, blah. I can draw pictures on the Zoom and it's so great. And we have our individual, like we have our one-to-one, like she can hear me, they can hear me, and we can have a really candid conversation. So I think multiple pre-op visits is not a bad idea. I think it's a great idea, actually.
Okay.
Yeah.
By the way, can I tell you that since you and I last spoke, a pelvic floor PT reached out to me and she said, I would like to do an interview with you on hysterectomies and pelvic floor PT. She told me that she has so many women with struggles around this that her entire practice is almost exclusively hysterectomy patients.
Oh my
I
gosh.
am not even kidding you. And so that is going to be the episode after this one, but it was recorded just given our schedules before this episode. It was mind blowing. And so she and I are actually going to have a discussion. She goes, another fascinating thing about our bodies is a link between endometriosis and hypermobility. And I raised my hand. I'm like, that's me. So we're going to do an interview on that. I'm going to do another one with her, but a really interesting
Wow.
discussion from her as well. But for like, what would you say is like, you know, honestly with you, I don't know if you'd be open to this. I feel like we should create a guide and like, it should be a handout so that they
Yeah.
remember, right?
Yeah, we could do that.
I'd be
Is that more work for me? Wait, okay. Yeah.
You could just dictate it like when you're traveling somewhere and I'll just put it together.
Okay. That's cool.
Put your name
I
on
like
it.
that.
Nonetheless, like what makes a good patient through this process? Like what should we do to serve ourselves and to help you?
I really think it's about asking the right questions. And that's so horrible to say because, like, if you think about it, if your doctor's giving you all the information, you shouldn't have to really ask all the right questions because all the information is being provided to you. But the exchange of ideas and information, it varies from person to person and between two different people. So I do think it's important to come with all the right questions. For instance, other than hysterectomy, is there another way to treat my condition that you would recommend? Like, and that question doesn't require you to know all the alternatives, but at least you're asking.
Okay.
Another thing is to make sure that, like, do not be afraid to say, I know you got to go. We're pressed for time. I get it. Can we please make another appointment? Because I do have a few more things I'd like to discuss and I need clarity because I'm not clear on it. And, you know, so don't be afraid to ask your doctor for more time. They won't be able to give it to you in the moment. But if you're open to coming back in a week or two or even a video visit, I think that that's critical because when patients say that to me, they're telling me, I'm hearing you, but I'm not getting it. I need more time. And I'm happy to come back another time, you know, because in the back of our minds is like, okay, I see my schedule. 5 people have shown up and I'm still sitting at, here at 2:00 with my 1:15, or something like that.
Right.
Or my 1:15 at 2:00. So to say that, just, hit pause, makes the doctor like stop and reconsider, and then you come back for another appointment. Notice how part of my recommendation is not to do research online, because research online for the layperson tends to focus on other patients' experience. And that's a whole nother topic, because that's about like the culture of being a woman in this medical corporate led infrastructure.
Yep.
But it's very hard to, I'm telling you, 90% of my patients are getting wrong information. 10% are going to like the websites of our governing bodies, like ACOG, the Menopause Society, and various other ones, like the ASRM for reproductive medicine. So if you go to those websites, they do have great patient information. So that, I would recommend that. I don't know if we can put up all the websites at the end of the podcast.
I'll put things in the show notes.
Yeah, I think that would be great too. If you want to like read about stuff, be immersed in it, and get a better understanding, so you feel more prepared for questions. Okay. But like TikTok and other patients' experiences, first of all, you don't know. You can't validate what someone is saying. They may just be saying something, and I don't want to invalidate it either. But I think it's difficult to generalize people's experience. I always tell my patients who are prescribing birth control pills too, I said, it is very well tolerated. The majority of patients tolerate it very, very well. There are patients who don't tolerate it, but they're in the minority, but they happen to be loudest about it. Like nobody's going online and writing what a great experience they've had with their pills. They're going online and writing about their horrific experience because they feel like they're doing good. I get it. You're sharing information, and I embrace that wholeheartedly, but we have to make sure that we understand what the facts are. Does that make sense?
Yeah, totally.
Do you want me to say that different?
No, that's perfect. So I guess a question then, I just want to address one of the things I brought up in the very beginning is stories I hear where women wake up from surgery and they're like, I can't believe I woke up and I don't have my uterus. Can you just address that, please?
I think it really depends on why the procedure was done. And there are only 2 instances in which I can picture that happening more commonly than others. One is a patient's going in for surgery for removal of fibroids. So the procedure is called myomectomy, whether it's done abdominally or laparoscopically or robotically, right? And robot and laparoscopy are both like minimally invasive with the little incisions. And abdominal myomectomy is we make an incision on your belly and we remove the fibroids. And the risk of having to do a hysterectomy during a myomectomy is very, very, very low. And for the most part, doctors do mention this very, very low risk, or should, during the office visit, during the time of the informed consent. Because it is important for patients to know that that's a possibility. It's so funny because this patient that I just did the hysterectomy on, we couldn't get I wanted to make the smallest incision possible. We couldn't get the uterus all the way out. So what we generally do is sometimes we just start removing the fibroids to make the uterus smaller so we can bring the uterus out of the incision and proceed with the surgery. And while we're trying to remove her fibroid, we thought to ourselves, oh my gosh, if we had agreed to a myomectomy with this patient, I don't know that we could have put this uterus back together. It was just, we would have had to do a hysterectomy. We were just discussing this in the OR while we're doing it.
Yep.
Just talking about like, wow, she's losing a little bit of blood and this is a very big uterus. And, we're kind of losing the anatomic, oh my God, I lost the word. Anyway, so we were discussing that in the OR, and it was very interesting that my team, they're the ones who raised it to me. It was very interesting that they did that. So, it reminds them that it's very, very important to discuss that. The other time that someone may wake up without a uterus is during some sort of obstetrical hemorrhage emergency. So they're having a cesarean or they're having hemorrhage after a vaginal delivery, and all other means of stopping the bleeding are not working. And then you do a hysterectomy. And if it's after a cesarean section, they call it a cesarean hysterectomy. And obviously after a vaginal delivery, you would just call it hysterectomy. But anyway, that would be, and then you wake up and you don't have a uterus, right? Because you were really bleeding and this was like a life-saving procedure. And typically with the myomectomies, if we have to do a hysterectomy, it's also because it's a life-saving procedure. Like you're bleeding too much, we can't control the bleeding. So you can do a whole nother podcast on myomectomy with preservation of fertility, because that's, that's another,
Wow.
that's a big discussion as well. But
Wow.
those would be the
Okay.
two instances in which someone would wake up without a hysterectomy. So I don't know what the context was for these folks that you've spoken to, but yeah.
Yeah, I don't know the details either. And, I think here's one. So please, people that are listening to this, do not please view this as me dismissing women. I wonder if a lot of this is this combination of, back to the beginning. We women don't know what we don't know about our bodies. Um, Most of the women I talk to say, I wish I would have known. And many of us who are building things to help women's health are really struggling because we see this gap where we're talking to all these experts, we're building all these amazing things, and we know the space very well. And we are genuinely struggling to figure out how to help women understand these are the things you should know or do in advance. And
Yeah.
so, like, how does one, like, in an emergency situation, like, I get the doctor has to save the life, and the woman is like, WTF, why didn't you tell me you might take my uterus? And so I see both sides, but the only way to do that is like women to just be aware, hey, by the way, if you're, losing a ton of blood while you're delivering your child, you may get a hysterectomy. Like, it's not like a common thing, right?
No, plus
And
there's so
so
many other topics to cover during your
I
pregnancy, like
know,
so
but
many other
that's
topics.
what's so, yeah, I know. And that's what's so, like, I think just frustrating for me. It's like, in serving all of these patients, because one, we never think it's going to be us. And again, this is not to put the fear, but this is just like, here are the situations when it can happen. And so I would love for people who may be listening to this to share your specific situation, because I would love
Yeah.
to know,
Yeah.
especially given the two main scenarios you're discussing.
I think the number one issue, or one of the main issues, is that women don't even have an idea of what their organs look like inside. Like for people, for men, I'm just going to use men and women as a binary, but for men, like everything is like it's there, like
Yep.
it's there, and they have a great understanding of it. And for women, it's on the outside. And even though we have charts and graphs and figures, it's like, but I don't know what it looks like. People show like hearts on TV. Like nobody's out there be like, this is a uterus in your, you know what I
Well,
mean?
on social media they are, because everywhere else is getting banned, but continue. Well, there's
So
actually an
I
organization
don't
called,
watch it. I only follow like other doctors who agree with me on social media. I like I like living in a bubble and just reinforcing my beliefs. But but I think that that's like a thing. Like and then we have to like find a way to like show them like this is what's inside and this is how it's all connected and this is how close it is to your bladder, to your rectum, and you know they don't even understand how close. Everybody thinks the ovaries are up here, and like no, they kind of just fall down with gravity, and
right.
so they don't even. It's so hard.
It is hard.
So I think
It is
that
really hard.
like really explaining the anatomy is important, and also like finding. And I don't know how to address this, but really fighting against the misogyny and the belief that it's this inert organ that if it's removed, whoop-de-doo, you're done making babies, so who cares? But it's not whoop-de-doo, you're done making babies, and who cares? We already know that even if you preserve your ovaries, you can go through menopause a little bit earlier. That can increase your risk for certain factors, for certain cardiovascular disease, and for cardiovascular disease. So we know these things. We know that it's not, let's just take out this inert organ. And I think more and more people are really understanding that. But, my most recent patient, she should have just had a fibroid embolization. I think it really would have worked very well for her. But she was like, just take it out, I'm done. and I'm not minimizing her. I'm not trying to say that she made the wrong decision. It was the right decision for her. But, did she come to that decision because she believes it's an inert organ and who cares? Or she doesn't believe that the embolization would help her, even though for people in her age group, it's like a 95% satisfaction rate in your symptoms. I don't know. I don't
Yeah.
know. But I wanted to also give her the autonomy. She made an informed decision. I gave her all the options. We discussed it all, and that's where she landed. But
And I
that
love
would be
that. I mean,
interesting.
it was clearly an informed consent
Yeah.
kind of
And
decision.
yet she came to that decision probably with this like paternalistic cultural history, you know? She's like, my
Possibly.
mom had it done. It's fine. Like that, you know?
Well, at least
So
it wasn't
that's,
someone like I will say if I ever, I think partly because of my fertility treatments, like I would be like in my bed under the covers for months if I had to get a hysterectomy. I think like when women tell me and they wish they didn't, my heart goes out because I'm like, I literally can't even put my head there. Like I think it's just like this. I mean, I'm in menopause, like, but still, just like the trauma of like it didn't work. I'm like, do not touch it.
yeah, I know.
It's kind of a weird thing, but that's just what it is.
It's not. It's
Um,
your thing. Yeah,
yeah,
I get it.
yeah. So, I mean, this conversation, like, I knew it would be a good one from the first time we met, but this was like absolutely fascinating. It's
Oh, that's
so
so
not. I mean,
sweet.
I love that you shared like from your perspective because, sometimes I even wonder, am I swayed by all the things I'm seeing on social media? Which is why I love talking to the doctors and being like, here's what I'm hearing. Like, is it true or not? And just hearing a balanced perspective. And so I really appreciate it. And I know this is going to be helpful for so many people. I guess, on the last note, on a positive note, like what's your hope for or your greatest desire for a change in healthcare? Or is that going to be another episode?
I can't even answer that. I'll say it this way. I would love it if everyone, irrespective of their immigration or citizenship status, had access to high quality healthcare in this country. So that's what I will say. And that's including all genders, all walks of life, and all ages.
Yep. We definitely deserve it. We all
Yeah.
do.
Yes.
Um, well,
100%. It's the
thank you.
humane thing. Yeah.
Yeah.
No,
Well,
thank
thank you.
you.
This was so much fun. I really, really appreciate your time. And I